Next, I'll invite Dr. Saptarshi Bhattacharya, who no need any introduction because he is among the one of the organizing team of endocrinologists. Without wasting time, I invite Dr. Bhattacharya to start your presentation.
Thank you, Dr. Sahu. So, thanks to all of you for coming here and connecting. It's a great pleasure to see you all again physically. So, I will be talking over the next 15 minutes or so about a molecule which I have started using recently. So, that is a molecule called evogliptin, and we all know it's like a DPP4 inhibitor. So it's a selective, potent, and reversible inhibitor of DPP4. So whenever a new molecule comes in, we are slightly apprehensive how much studies are there to back its usage, what is the scientific evidence behind all that. So it originally was approved in Korea in 2015, and after that in multiple other countries, and in India it was approved by the DCGI in August 2018. The dose is around 5 mg once daily. So we know that there are some differences between the DPP4 inhibitors. So the principal site and that difference relates to the site of action in the DPP4 enzyme. So there are 5, S2 and S1 are the main targets of all DPP4 inhibitors, and there are other subsites like S2 extensive, S1 dash, S1 prime and S2 prime. So binding to additional sites can provide additional DPP4 inhibition and increase the effectivity of the molecule. And these are the classes broadly. Two broad classes of DPP4 inhibitors are there depending on their site of binding. One is class 1, which binds to S1 and S2, and vildagliptin and saxagliptin belong to that group. The other group is class 2, where the molecule, the DPP4 inhibitor binds to S1, S2, S1 prime and S2 prime, and linagliptin and allogliptin belong to those group, and evogliptin also binds to S1, S2 and S2 extensive binding sites with non-covalent bonding. And the pharmacokinetics, it reaches a peak at 3 to 5.5 hours. DPP4 inhibition rapidly surpasses 80% in less than 1 hour, and the terminal half-life is 32.5 to 39.8 hours. So it does not have any induction by any other enzymes. It's not an enzyme inhibitor, and no dose adjustment is required because primarily the excretion is it's an urinary excretion, and dosage and administration is even in moderate hepatic impairment, that we'll see from the studies, it does not require any alteration. So it maintains a more than 80% DPP4 inhibition even after 24 hours. The GLP-1 postprandial levels are go up by almost 1.5 to 2.4 times, and the postprandial glucose level that goes down by 20 to 35%. So there are multiple studies. So there are phase 3 international studies which initially led to the introduction of the molecule. Then there are efficacy and safety of evogliptin in treatment of type 2 diabetes mellitus in Brazilian population. The bridging study, it was a randomized control trial. Once daily treatment of evogliptin, 5 mg, you can see the HbA1c almost came down by 1.3. So there was with 10 mg it came down by 1.33, with 2.5 mg it came down by 1.08. So it was more of a dose finding study, and 5 mg was the usual dose that is approved and that is used all over. So again, there are evergreen studies presented in ADA 2019 where evogliptin was compared to linagliptin. So there was no major difference in HbA1c, similar non-significant difference in HbA1c reduction over 12 weeks. There is no difference in glycemic variability as well. That is a concept which is rapidly evolving, and even if these patients were further followed up till 24 weeks, there was no change in HbA1c. So effectively, we know that linagliptin is a very standard molecule which has been very extensively studied, and it does reasonably well in comparison to linagliptin even in randomized controlled trials. So these are reassuring findings in terms of their safety and efficacy for patients with type 2 diabetes. So, a very common question again that comes to our mind is whether we can use them in chronic kidney disease patients, because gliptin, as we all know, has emerged as a very safe way to treat type 2 diabetes and CKD. So, because they do not have the risk of hypoglycemia, they can be used in most stages of chronic kidney disease, and there was a clear this study was specifically meant for patients with chronic kidney disease, and all patients, all stages of CKD, but except those who were on hemodialysis, so they have not been studied. So CKD stage 1, CKD stage 2, CKD stage 3, CKD stage 4, that is, even if the GFR is till 15, you can safely use evogliptin without alteration in the dosage. So it's as similar to linagliptin in terms of that. But for end-stage kidney disease patient who are on hemodialysis, we do not have adequate data. Again, another area which is a very common complication of type 2 diabetes, even type 1 diabetes also sometimes, is NAFLD. So there are two aspects to it. So whether using a glip, there are some studies which suggest that gliptin can be beneficial to maybe the liver fibrosis scores or the liver fat content, and whether you can use safely in the setting of chronic liver disease. So there are initial small studies which suggest that they can be slightly beneficial in chronic liver disease, and there are trials which suggest that they can be safely used for childhood stage 1, stage 2. For stage A and B, we do not have adequate data for childhood C. So in those group of patients, it should be avoided. But in initial stage A and stage B CLD, you can safely use it. So another area which has generated a lot of attention is cardiovascular safety. So we do not have a dedicated cardiovascular outcome trial for evogliptin as of now, but we have a nationwide population-based cohort study in South Korea. It was more of an exploratory objective, and the clinical and demographic characters of patients with type 2 diabetes on glimepiride, DPP-4 inhibitors and SGLT2 inhibitors were compared. So it was more of a observational registry-based study, and the study concluded that the use of evogliptin either decreased the risk of CVD or had no association with CVD compared to other ingredients of DPP-4 inhibitors or SGLT2 inhibitors. So it's as safe as other DPP-4 inhibitors or SGLT2 inhibitors, and even there were some suggestions that there were a trend that if you are comparing glimepiride to DPP-4 to evogliptin, actually it did better in comparison to glimepiride, though in an observational setting in terms of CV outcome. So we now look into some of the combination studies where we study the combination of evogliptin and metformin. So these group almost close to 1,000 patients were studied in different randomized controlled trial. There also they showed adequate safety, adequate HbA1c reduction. Even there are Indian studies, multinational global studies. So this is a molecule, as you can all see, has been quite extensively studied in Korea, in Indian setting, in other countries also, and it has done well in comparison to linagliptin. Even it has been compared to sitagliptin. It's CV safe. It can be used in stage childhood A and B, chronic liver disease. You can use it in most stages of CKD unless the patient is on hemodialysis, and there are no additional adverse effects as compared to other DPP-4 inhibitors. So in terms of total adverse effects or pancreatitis, they are as good or as safe as the other DPP-4 inhibitors. So we again, hypoglycemia risk. So if the person is not on sulfonylurea or insulin, you will not be the person, again the risk of hypoglycemia is practically nil. And we have the latest data from India also, where a retrospective observational study of usage of evogliptin in type 2 diabetes patient. So that also suggested that it was quite safe. The results were HbA1c decrease was almost more than 1.2%. So multiple even CGM data suggests that they do quite well. So effect of evogliptin on addition, there are studies where it has been studied after metformin and glimepiride combination. Again, good encouraging data. 8.8 was the baseline H1C, it came down to 7.8, and the fasting blood sugar came down from 159 to 128, the postprandial came down from 238 to 188. And there is an active post-marketing surveillance of the fixed drug combination of evogliptin and metformin going on, and so it's a film-coated bilayer tablet, and so the change in HbA1c is comparable to even if you are giving it differently. So overall, as you can see, it's a safe molecule. It's comparable to all other gliptins in terms of safety, efficacy, HbA1c reduction, usage in chronic liver disease, usage in chronic kidney disease, no major enzyme interactions, no enzyme induction, no issues related to enzyme no other enzyme inhibitory effects. So overall, it's a quite safe molecule, and the HbA1c reduction in most of the trials has been in the range of 0.7 to 0.8. If the HbA1c was very high at baseline, even it has come down by 1.2 or 1.4%. So this was a meta-analysis of usage of evogliptin, which was published by Deep. I was also fortunate to be part of this meta-analysis. So there also we found that when it was compared to other gliptins, so it's almost similar to most of the other gliptins. So it's equally safe, equally efficacious. Even we have meta-analysis which is published in Indian Journal of Endocrinology and Metabolism to suggest that. So to summarize today's presentation on evogliptin, it's a truly once daily DPP4 inhibitor. So you need to just give it only once. Long half-life of 32.5 to 39.8 hours. It has data to support its CV safety, renal safety, hepatic safety. There is no need to change dosage in various stages of CKD. In the Evergreen study, which is a 24-week study, which was where evogliptin was compared to linagliptin, it showed highest reduction in glycemic variability. Sometimes it did better than linagliptin in terms of reducing glycemic variability, and did as well as and was non-inferior to statistically to linagliptin in terms of HbA1c reduction. With 3 head-to-head studies against sitagliptin, evogliptin also has been proven to be non-inferior versus sitagliptin, and we have a Indian study called Evolution India also, which suggests that it is as safe as sitagliptin. So evogliptin metformin sustained release combination. So sometimes what we see in clinical practice is that most of the DPP4 metformin combinations, they have an immediate release preparation of metformin along with the DPP4. So sometimes patients do have issues related to GI side effects and GI tolerability, but the metformin in this combination is a sustained release metformin. So sometimes if the patient who is not able to tolerate a immediate release metformin, we shift to a sustained release formulation, the GI side effects somehow actually settles down in many of our patients. So in the metformin, in the evogliptin metformin combination is a sustained release, so that is actually helpful for patients who have GI side effects related to metformin, and can be considered as a once daily dosage for many of these patients. So if we have a comparison to other DPP4 inhibitors, the percentage of DPP4 inhibition is almost similar. It's like 80, it varies between 90% to 90 to 80% for most of the DPP4. So its overall DPP4 inhibition is 80%. Selectivity is high. Dosing, it's once daily dosage. Dose alteration in renal disease is not required. Dose alteration in hepatic disease, so you can give without any dose alteration in child-pugh B and A. HbA1c lowering versus active comparator, so it's very similar results. QT prolongation, it does not cause, so there are some issues with teneligliptin in terms of QT prolongation, so this is not there. Risk of hospitalization for heart failure, so even though we don't have an dedicated CV outcome trial, but whatever initial data we have, there is no risk of hospitalization for heart failure. And above all, in Indian setting, cost always remain a important deciding factor about which drug to prescribe, and this is not a molecule which is very costly. So it's not as costly as the conventional gliptins we have in market. So this is a new molecule with adequate safety data which you can consider in many of your type 2 diabetic patients. Thank you for your patient listening. So I will hand over the session now back to the chairpersons. Thank you.
I have a question. Thanks, Dr. Saptarshi Bhattacharya. So, regarding your excellent presentation about this new molecule, evogliptin. So, if anybody has any question.
Sir, as the half-life is quite long, 32 to 39 hours, what about the cumulative effect after, say, week dose or after 10 days? Some amount of drug must be there in the blood already.
See,
before the previous
so we are actually looking at a DPP4 inhibition. So that will be at the end of 24 hours if how much DPP4 inhibitory activity is present. So that is almost, so that remains static. So even though some of these drugs do have extended half-life, they do not have any cumulative effect as such.
Thank you, Dr. Saptarshi, for this nice presentation. I have a question that among all gliptins, where do we place this gliptin for cardiac patients? We do not have a dedicated CV outcome study with this.
Yeah, I think I wish we had. So obviously, if you look into hard evidence, so if what you have for maybe sitagliptin or linagliptin, we do not have that for evogliptin. We have some data related from a registry which is Korea based, but if somebody is having a genuine cardiovascular disease, you have data from linagliptin or sitagliptin which suggests that it does not increase the risk of heart failure. So, but we do not have such data from evogliptin. So maybe your approach should be slightly guarded. So you can even we see very often patients getting teneligliptin which does not have any CV outcome trial. Even we do not have CV outcome trial for vildagliptin. So if you are looking at really safe CV outcome, really robust CV outcome data suggesting CV safety in patients who are having some amount of cardiac compromise. So we only have sitagliptin and linagliptin as molecules if you are looking into hard evidence. So otherwise you can extrapolate. Evogliptin is available. It's freely available. Yeah.
Thank you. Thank you.
Thank you. Thank you.